professor of obstetrics and gynecology at Cairo University. He is the founder of the Egyptian IVF Center, the most famous IVF center in Egypt. He is a founding members and the founding president of the Middle East Fertility Society, but more importantly for us at the Royal College, he is the laureate of the gold medal of the Royal College of Obstetricians and Gynecologists. We will be very pleased to hear him speak about introducing new technologies in IVF. Did it improve the outcome? I would also like to introduce and welcome Professor Johnny Awad. Professor Johnny Awad is Professor of Obstetrics and Gynecology in Reproductive Endocrinology and Infertility at the American University of Beirut Medical Center. He is a former clinical instructor at the Harvard Medical School in Massachusetts General Hospital in Massachusetts, of course, the United States of America, and is a past president of the Middle East Fertility Society. We will hear him talking to us about pre-IVF treatment of endometriosis. I would also like to welcome our third colleague and friend, Professor Boutros Rizk. Professor Boutros Rizk is Professor of Obstetrics and Gynecology at the University of South Alabama in Mobile. He's a former clinical lecturer at Cambridge University. He used to work with Professor Bob Edwards, who received the Nobel Prize in 2010 for his introducing IVF in women's. And he's Professor Rizk is also a past president of the Middle East Fertility Society and the founder of the Elite IVF Center in Texas. He's an author of 28 books at least in infertility and assisted reproduction, and we are going to hear him speak about controversies in assisted reproduction. I would also like to welcome my dear friend and colleague and my co-moderator today, Dr. Michelle Abu Abdallah. Dr. Michelle Abu Abdallah, for those who know the Middle East Fertility Society, is of course the head of the Middle East Fertility Clinic in Beirut in Lebanon. He's a former fellow of McGill University in Montreal in Canada in reproductive endocrinology, infertility and andrology. He's a co-founder of the Middle East Fertility Society and also a past president, and he's the executive director of the society, and he is a member of the American Society for Reproductive Medicine International Committee. And I would like also to thank Minafan Pharmaceutical for hosting this webinar today or tonight. They have been always very helpful to us in many of our activities. And I would like you to please share with your questions. We will have a question and answer section at the end of the webinar. So please post these questions in the question answer section, not in the chat section, in order to facilitate things. And you please mention your name and country if you like, because I know that we have people from different corners of the world. And so welcome, ladies and gentlemen, to this webinar. And now I will go to share to leave my screen and my microphone to my dear colleague, Dr. Michelle Abu Abdallah. Dr. Michelle.
Thank you, Professor Salam. I'm pleased and honored to share with you this webinar. And on behalf of the Middle East Fertility Society, we are proud always to collaborate with the Royal College of Obstetricians and Gynecologists, and especially the group in Egypt. As you quite all know, because you are one of the co-founders of the society, that the Middle East Fertility Society was established in 1992. It's a professional society whose mission is to improve fertility care of couples in the Arab world and in the Middle East through the transfer of medical knowledge and the promotion of scientific research. The society has become a vehicle of knowledge dissemination and a platform for research collaboration in the whole region. Of course, our annual scientific meeting has traditionally become the meeting point where all fertility specialists across the area find the opportunity to exchange scientific information, renew social bonds, strengthen national solidarity, and consolidate cultural heritage. On this occasion, I'm glad to announce that this annual meeting for the year 2020 will be held in Amman next December 3, 4, and 5. Professor Awad and Professor Abul Ghar are helping much on the scientific work to establish an interesting scientific meeting. So I'm glad to be here with you, dear colleagues, and I leave the panel again to Professor Hassan Salam.
Okay, thank you very much, Dr. Michel. And I think it's about time now to welcome Professor Muhammad Abul Ghar, who is going to talk to us about introducing new technology in IVF. Did it improve the outcome? Professor Abul Ghar, please share your slides with us.
Good evening, dear colleagues. Thank you very much, Professor Salam and Dr. Michel. And my talk today will be introducing new technology in IVF. Did it really improve the outcome? And we know that there are certain milestones which really improve the IVF outcome, including stimulation protocols, including ultrasound monitoring, rapid hormone assays, vaginal aspiration of oocytes, and advanced culture media, and the last of them was introduction of ICSI, which was in the mid-90s. Since the mid-90s, there were tens of new procedures and techniques which was introduced to improve the IVF outcome. And there were hundreds of studies which were published. The important question is, did all these new techniques and procedures, did it really improve the IVF outcome? Read what Peter Brody and Johnson published very recently in the British Journal. This sentence, can you imagine any other branch of medicine or surgery accepting a working with 70% failure rate, which is a real status of IVF? The live birth rate is not more than 30% or around that anywhere. And if you look at the birth rate per fresh cycles from the results of SART, you will find out that the birth rate was increasing gradually, and then it became sort of stationary. And in the last years, the pregnancy rate and the live birth rate dropped in the United States of America, and these are the SART results. And if you look at other countries like Canada, Australia, New Zealand, you will find the same thing. The pregnancy rate is going down all over the world. We know that there are certain procedures which were performed during the past years, and it proved to be not effective in improving the pregnancy rate. But they didn't have a negative impact. Hysteroscopy, routine hysteroscopy, time lapse, natural killer cells, use of aspirin, heparin, corticosteroids, immunoglobulins, all these procedures proved to be completely and absolutely useless in improving the outcome of IVF by large randomized studies. But they had no negative effect on the outcome. So what is the reason of the decline in the IVF outcome worldwide? Procedures which may possibly reduce the IVF outcome and the results in the decline could be the more use of natural cycle IVF, with or without modification. It is simple, cheap, no cryopreservation, but definitely it is associated with a lower pregnancy rate. And the same applied for all types of modified natural cycle IVF. Again, there were lots of talks about mild ovarian stimulation, and there are societies for mild ovarian stimulation. And I'm going to take the example of Japan. From 2004, Japan have the lowest IVF pregnancy rate in the whole world. And this started This decline in the pregnancy rate in Japan coincided with the introduction of the Kato protocol, which everybody talk about it as something fantastic, use of clomiphene citrate and very small dose of HMG with mild ovarian stimulation and single blastocyst. And it is associated with a very low pregnancy rate. We know that GnRH antagonist was introduced many years ago, and after some years, this Cochrane review showed that there is no difference between agonist and antagonist concerning the live birth rate, and ovarian hyperstimulation is lower with the antagonist procedure. However, if you look at this meta-analysis, which was rather recently published, including 50 studies, the studies were separated into two groups. One group is normal patients, which is the majority of patients, 34 studies. And then the other group is hyper-responders, polycystic ovary, and the poor responders. In the normal responders, the agonists proved to have a significantly higher pregnancy rate. And in the lower responders or higher responders, there was no difference between the groups. So this study points to the fact that possibly excessive use of antagonist protocol may be one of the reasons why the IVF rate declined when it is applied to all patients. And again, we now, with the antagonist protocol, we use a lot of triggering ovulation by GnRHA. And it is a fact that triggering ovulation is associated by GnRHA with a lower pregnancy rate as compared to HCG. So, but it is important to use it because you are going to reduce the incidence of ovarian hyperstimulation syndrome. But excessive use, of course, will result in a lower pregnancy rate. And this is a meta-analysis which shows clearly that whatever you do, giving small dose of HCG, giving progesterone, excessive dose of progesterone, whatever you do, you will still face the problem of a lower pregnancy rate in all randomized studies. And this is a meta-analysis which shows this clearly. Freeze-all policy. Now there is a trend all over the world to use more frequently freeze-all policy. Freeze-all policy is being done mainly for hyper-responders to avoid ovarian hyperstimulation syndrome. And this is approved by everybody. But there are many other indications like repeated implantation failure, advanced maternal age, endometriosis, and high progesterone level on the day of HCG. All these indications are not proved, and freeze-all policy may decrease pregnancy rate and delay pregnancy. That's why it should only be done in the hyper-responders to avoid OHSS. Ovarian zona thinning and zona drilling proved to be not effective, did not improve pregnancy rate, but manipulation in the embryo might reduce the pregnancy rate. And endometrial scratching, we know from the PIP study, clearly it's a multi-center large study that it is not effective. But in this meta-analysis, which was done on a number of studies, if you look here to this subgroup analysis, showed that scratching in the same cycle of oocyte retrieval reduced significantly the live birth rate. So again, endometrial scratching, if done in the same cycle, may reduce the live birth rate and may affect the pregnancy. Now, prolonged in vitro culture conditions. Unless they are optimal, they may affect the IVF outcome. Everybody wants to transfer blastocysts. But if your culture conditions are not optimal, you will end up by very poor embryos, not reaching blastocysts. Maybe you have to cancel transfer completely. So there are risks of extended culture unless it is very optimal. And again, we know that transferring blastocysts have a higher live birth rate in cases of fresh embryo transfer. But the cumulative live birth rate in one cycle, if the patient starts stimulation today and transfers all the embryos, there is no difference between blastocyst transfer and divided or cleaved embryo transfer in the live birth rate. But for the fresh, of course, the blastocyst transfer is better. So why do we culture embryos to blastocyst transfer? Because our aim worldwide is to transfer a single embryo to achieve one baby and to avoid multiple pregnancy and higher order pregnancy. So does not, in double transfer, blastocyst does not offer an advantage. If you are not planning to transfer only one blastocyst, if you transfer 2 blastocysts or 3 blastocysts, you will face a lower live birth rate because you will have abortions, higher premature deliveries with loss of the babies. In countries where they are not going to transfer one blastocyst, the idea of culturing the embryos to blastocyst stage is not always very advisable. How many embryos are you going to transfer? Single, double, or more? In this Cochrane review comparing single and double, it is clearly shown that single embryo transfer have a lower live birth rate. We know if you transfer 1 embryo, you have a less pregnancy rate than you transfer 2 embryos. Single embryo transfer significantly reduces, it is good because it reduces multiple pregnancy. And it lowers pregnancy rate as compared to double embryo transfer. So the implication depends upon the methods of financing IVF. If you are in a country where the IVF is covered by social insurance, then it's a good idea to transfer single blastocysts, and if it doesn't work, to do it. If it doesn't work, you have to do another cycle because the patient will not pay anything out of our pocket. But in areas where the system does not allow this social welfare system, you have to think about it. Is it better to transfer 2 embryos than 1 embryo? Is it wiser to continue to blastocysts for all embryos or not? You have to think about it. And in Canada, after the introduction of single embryo transfer in Quebec, the number of babies born was 33% fewer. So single embryo transfer clearly reduces the pregnancy rate, the live birth rate, and the number of babies born. And again, in Australia and New Zealand, which was applied extensively, single embryo transfer to avoid multiple pregnancy, the live birth rate also dropped markedly. This we have to put in consideration. So we have to balance between reducing multiple pregnancy as compared to reducing the outcome of IVF. And as I have mentioned, it all depends on the medical care system in this particular country, which guide you to choose the best. What about endometrioma? Endometrioma does not affect the IVF outcome. Endometrioma clearly, if surgically removed, will reduce the ovarian reserve. Whatever you do, it will reduce the ovarian reserve, it will reduce the AMH, the number of oocytes. There is a risk of no additional benefit of surgical treatment of endometrioma. And it not only no benefit, but there might be harm after doing this. If you have an endometrioma, doing these surgeries reduce the outcome of IVF following reducing that. Again, overdiagnosis, overdetection, and overdefinition of the substitutes. So far, there is not one randomized study which is finished and published which shows that the uterine septum any harm or cause any problem for the outcome of IVF. Again, uterine septum are different types of uterine septums. You have a small, big, large, thick, thin, etc. Definitions is not clear. doing surgery for the septate uterus without any evidence, you will only be left with possibility of harm to the cavity of the uterus, which might lead to permanent infertility if done with unexperienced hysteroscopist. So before doing a large good randomized study, we should not consider the septum before doing IVF. And the last part is PGS or PGT. We know that in 2011, this very famous analysis, meta-analysis, which was published, clearly showed that PGS, pre-implantation genetic screening and testing the chromosomes, at that time was done by FISH for 4 or 5 chromosomes only, did not improve the pregnancy rate and even reduced the pregnancy rate. So there was a final call all over the world, stop PGS, and actually PGS was stopped for a number of years until a new technology developed, the array CGH or the NGS, next generation sequencing, which is faster, produces the result faster. This examines all the 23 chromosomes of the patients, and then people start to think again that we might start doing pre-implantation genetic testing or genetic screening, and it may be useful. So how are we going to calculate the results of PGS or PGT using these things? The only solid data comes from cumulative live birth rate per woman per one started cycle. You have the patient today, she started stimulation, the patient wants a baby. At the end of the cycle, if you have frozen embryos, and it should be also transferred, and then you should do your counting. If these women are doing better, they are having more babies, then this procedure is working. So let us see what is the result of PGS concerning the live birth rate, cumulative live birth rate. There are two very, very big studies. The Illumina, the STEAM study, which was between Eshley and Illumina, which is the main company producing all the material for the PGS. This is a very large study, and all the chromosomes were analyzed. And if you look here, you will find that the number, or it is of course a randomized study, the patients who have live births, one live birth rate, were 42 in each arm if you do PGS or you don't do PGS. The number of clinical pregnancies were higher if you don't do PGS, and the number of babies were higher in the no PGS because of a few twins occurred more here. In this study, transfer of 2 embryos was allowed. The largest American study was done rather recently, finished last year. This is again PGS or PGT versus no PGS versus only look at the embryos. It was a very big, large randomized study, over 600 patients. The end result of the study is that PGT did not improve the ongoing pregnancy rate in the study group. They did not put the endpoint as the live birth rate. They only put it in that study, the ongoing pregnancy rate. And this study was totally sponsored by the company producing the material, Illumina, which of course had a big interest to show that it really worked. Then they did some subgroup analysis, try to find out something to say, but the result is very, very clear. There are other 3 smaller randomized studies which showed no difference, and adding all this together, it is clear that PGTA, pre-implantation genetic testing or genetic screening, has no improvement in the live, does not improve the live birth rate. PGT, because of its high false positive diagnosis, a large number of perfectly normal embryos are routinely discarded. From the day the PGS was developed, embryos were thrown in the garbage, while these embryos could have produced healthy babies. We know that mosaic embryos were thrown away. And now we know in this study that 41% of the mosaic embryos can implant, produce normal pregnancy and healthy babies. And even completely unemployed embryos, completely abnormal embryos, you can have a normal babies from these embryos, because there are different explanations for this, which I'm not going to go for. So PGS for unemployed screening will never ever improve the live birth rate per started cycle, but it may decrease the IVF outcome by not transferring embryos which have a possibility to implant. It is very clear, PGS is a test. It is a diagnostic test of the embryo. Will diagnostic test improve the condition of the embryo? Will make it a better embryo? Of course not. So the only thing is that it will tell you this embryo looks by the chromosomal pattern better than this embryo. So maybe you transfer this embryo first and the other embryo next. That's all it is going to do. The PGS or PGT is an extremely expensive procedure. It is very, very expensive. We do this procedure for a number of indications, not unemployed screening. And it costs us, it doubles the price of IVF, and if the number of embryos are big, it even triples the cost. The end result is that patients will be able to do only one cycle. If it doesn't work, they don't have more money to do other cycles for no reason. So my conclusions, that a number of new techniques were introduced in IVF technology from 1995 without any evidence that it improved the outcome. There are hundreds of papers, hundreds of procedures, hundreds of very expensive things. We buy lots of things and we use lots of things. It doesn't work. And there is no cost-effective analysis was done on any one of these techniques to show how much it costs the patient, and it harms the patient, it harms the economy of the patient, and it decreases the number of IVF. A code of ethics with the useful new procedures should be published and distributed to all people involved in ART units. And large randomized studies for any new technique should be performed before its implementation into practice. There are many of these procedures were practiced without any randomized studies. And it is not the time, is it not the time that our professional societies and reduce the IVF outcome, and possibly these procedures or these techniques is the reason why the IVF pregnancy rate is dropping in America, is dropping in Australia, is dropping in Canada, because of excessive use of different procedures at time. And finally, I'd like to thank our team. These are the doctors and embryologists in our unit. And I would like to thank Professor Salam and Dr. Michelle Abu Abdallah and my good friends, Dr. Johnny Awad and Dr. Suez. And I hope you will have an interesting meeting, and thank you very much. You are mute, Dr. Hassan.
Thank you very much for unmute.
Okay. Okay.
Yes, sir. Thank you very much, Professor Abulgar, for a wonderful presentation, as always. We will leave the questions and answers at the end of the session. But maybe I would take the privilege of asking you a quick question. Do you mean that PGTA is dead by now? It doesn't have any use? Because some people say that it shortens the time to pregnancy. So what do you say about that?
There is not, it might increase the implantation rate. It might increase the number of early abortions, but it will never ever improve the take-home baby rate. Never ever. And there is no proper study which showed is it going to shorten the time for the first pregnancy, and how long is this period? The only study done by the Dutch group showed that it reduces the time to pregnancy by 11 days. So does 11 days pregnancy earlier by ripping needs to do all this fuss and all this mess and all these costs. But there are indications, of course, for genetic diseases, for hereditary conditions. Of course, you have to do, but not for unemployed screen.
Thank you very much, Professor Abulghar. Now I pass my microphone and screen to Professor Michel Abu Abdallah for introducing our next speaker. Professor Abu Abdallah.
Yes. Well, I'm glad and honored to introduce Professor Johnny Awad. Professor Awad is my dear colleague. He's chairing the scientific committee at the society. He's a well-known figure. He's got an outstanding personality that makes him communicate extremely well with his patient, with his peer, with his colleagues, and he's done great work at the society. Professor Awad, I'm honored and pleased to introduce you to the panel. Please go ahead.
Thank you, Professor Michel. This is really, I'm honored by this presentation. I don't deserve. Thank you very much for your friendship. I would like to thank Professor Salam also for this wonderful collaboration. Putting this together with the Middle East Society is a great venture, which we all support as well. Thank you very much for having me here to discuss today a topic we all deal with in our daily practice, endometriosis. And we all deal with certain dilemmas. And unfortunately, despite, as Professor Abulghar mentioned, despite the presence of significant evidence on how to manage endometriosis, we're often biased because gynecologists, like all surgeons, are people who like to use their hands, their skills, and we're all tempted by doing procedures. And often at times, these procedures might not be of proven benefit and or might be of harmful effect. This is the best example. This is a case, a 30-year-old woman who typically has a normal semen profile, coupled with normal profile, normal tubes, but who presents with, she's young, presenting with bilateral endometriomas. How do we go about managing this woman's infertility? Do we go for surgery? Do we simply overlook and forget about the endometriomas and move on to IVF? In the case of failure of natural conception, this remains a dilemma. And I'm going to try in the next few slides, based on what we have in terms of evidence, because often at times the evidence is there, but sometimes it's not of high quality. We try to answer that. But we have to remember, we're going to try to do a little exercise in evaluating the word literature on that basis. So managing endometriosis is a very intense risk-benefit analysis, right? The benefit is based on available evidence, sometimes not of very high value, but also we have to look at it from a different perspective. We should look at it from the presence of risks, and that is usually financial burden, psychological stress, and physical as well, physical harm. Before we start managing endometriosis with IVF, I think a couple of topics need to be addressed. Early stage endometriosis, how does it perform following surgical treatment, fulguration or removal? And that is with respect to natural clinical pregnancies. Unfortunately, there are only 2 randomized trials, high quality. This is one of them, the Canadian Collaborative Group on Endometriosis, which were published couple of decades ago, actually, in which women who were diagnosed with minimal and early stage endometriosis were randomized into either, at the time of laparoscopy, surgically removal of these endometriotic lesions or keeping them behind, and then enabling these women over the next 1 year to conceive naturally, spontaneously on their own. And if you look at the 36-week cumulative probability of getting pregnant following surgery, it's 30% compared to 17% with no surgical intervention. A significant, statistically significant improvement of 17% in a cumulative pregnancy risk. Now, this is significant in terms of statistic. And when you look at it, you think this is the most wonderful thing, and you offer it to the patient supported by a high quality level 1 evidence. But I have to warn you, sometimes we have to include the patient values, interests, and input on what we do. And sometimes we have to share the data from the patient perspective. Physician's perspective, this is a great surgery. Patient perspective looks differently. So if we tell the patient, if I do a laparoscopy for you and I find early stage disease and I treat it, your chance over the next 1 year is 30%. If I do nothing, it's about 20%. So your net benefit, your actual benefit is 10% improvement in pregnancy rate over the next 1 year. So if you tell the patient the truth from her own perspective, what is her answer? Doctor, are there any better alternatives with a shorter time to pregnancy? Is there something that gives me a higher pregnancy rate, right? So the way we interpret things and counsel our patients is very important, right? So this is one. Now let's look at advanced stage endometriosis, stage 3 and 4. When we treat them surgically, how does it impact natural pregnancy afterwards? Unfortunately, we have no randomized trials of high quality here. Most of these studies are just like this one, observational ongoing pregnancies and studies. And this is a study from Italy that showed on 222 patients that when you treat early stage disease with patency of the late stage disease with tubal patency, the chance to conceive over the next 3 years is going to be 50%. Over the next 1 year, 40%. But if the patient tells you, I don't want to wait that much, over the next 6 months, it's only 10%. And this is the observed effect. We do not even know the actual benefit because the actual benefit could be much less than that. So actually, when we counsel our patients, unfortunately, we tell them you have a 50% chance after my surgery, but we fail to complete the sentence and look at the time to pregnancy. This is a meta-analysis of, unfortunately, retrospective studies, case series. And the case series, the major weakness is selection bias. So if I have a series, I'm proud of my performance, I publish it. But if I have a study that showed negative effects and my surgical intervention is really non-beneficial, I'm not interested in letting everyone know about it. So this is certainly a biased meta-analysis, but it shows clearly the number 50 comes back. And so it confirms again that the chance to conceive spontaneously following surgical treatment of endometrioma, 50%, but we should share with our patients that this is over the next 36 months, 3 years. And so the patient will tell you, are there any better treatment alternatives? And is there a better way to conceive? Now let's come to the effect of medical treatment of endometriosis on natural conception. Beyond any doubt, this is probably the only thing in the field of endometriosis where you have a significantly high level of level 1 evidence, randomized trials everywhere, all of which, as you can see in this meta-analysis, confirmed that the treatment of endometriosis for the purpose of improving natural conception, with the use of ovulation suppression, whether danazol, whether birth control pills, whether GnRH agonist, is totally not beneficial. And there's no doubt about it. In this meta-analysis, it looked essentially at the use of GnRH agonist suppression in these randomized trials after surgery. That, in other words, the scenario is very typical. You go into surgery for endometriosis advanced stage. You feel you did a great job, but unfortunately there are some places you could not access here and there. So you tell the patient, you know what, in order to complete the benefit, let me put you on GnRH agonist for the next 6 months before you try to conceive naturally. This is unfortunately common practice. And as you can see, all the evidence, level 1 evidence, will tell you this does not improve the pregnancy success. And so this is the best kind of evidence, level 1A. And on the contrary, it tells you there are adverse effects. Financially, the cost of the medication, physically, the hot flushes, the headaches, the weight gain, the bone loss, emotionally, the depression, the delay in pregnancy. So not only that, there's a proven benefit that does not work and should not be used, there's also a tag. There's a number needed to harm of 21. So you're even harming your patients, and therefore this should never be used. And that it is not acceptable under any circumstances with this kind of evidence to see any one of us given GnRH agonist after surgery to enhance spontaneous pregnancy. Now we come to the heart of our discussion. A patient comes with severe endometriosis and tells you, and you tell her we're going through IVF because we've tried any other method and it's not working. And the first question she tells you, I've read somewhere, I've been counseled somewhere that endometriosis it affects my outcome with IVF. So how are we going to answer this patient? There are numerous meta-analysis and systematic reviews, certainly of observation studies at this stage. So not the best quality, but that's the available kind of studies to prove the effect of endometriosis on IVF. And it shows clearly, especially this is one of them, that early stage disease does not affect clinical outcome. In this particular meta-analysis, late stage disease appeared to affect clinical pregnancy, implantation rates, but not live birth rates. However, this association that some meta-analysis showed is not a cause-effect relationship. It's a simple association, and that does not mean at all that treating endometriosis will necessarily restore pregnancy outcome to the level expected without the disease. Now look at this meta-analysis that looked into the impact of endometriomas over ICSI. So these were patients who had an intact endometrioma versus patients with no endometriomas. In this study, it showed that the presence of an endometrioma did not appear to affect the live birth rates with IVF, nor the clinical pregnancy rates, nor the miscarriage rates. It did, however, affect the cancellation rates. It did reduce the number of retrieved oocytes, and it was associated with a reduction in the ovarian reserve in general. So endometriosis appears, especially the severe form, to be affecting in some way the reserve of these patients. Now, as you can see, there is some controversy in these findings, but if you put all the available meta-analysis together in one study, there are 5 of them. All of them agree that stage 1, stage 2 disease do not affect the outcome of IVF. 2 out of 3 will tell you it affects clinical pregnancy rates, and only 1 out of 5 will say it affects the live birth rate. So I think this is where the data are. This is not great data. These are low quality beta analysis. However, this is the available data that we need to share with our patients. Now, this is an interesting retrospective study looking at the prognostic factors that would affect the outcome of IVF in women with endometriosis-related infertility. And the only 2 significant prognostic factors are low ovarian reserve and previous surgery for endometriosis, especially endometriomas. And please remember this, these 2, you ought to avoid them because these are the only ones that have shown to be significantly affecting your outcome of the IVF. Now, a patient comes with endometriomas and you wonder if surgery is going to be beneficial to improve the outcome. I know many schools, some of them in the US, some more in Europe, would tell you treatment of an endometrioma will improve the outcome. There is unfortunately a single randomized trial from Turkey that addresses this issue, a single RCT. And this study have shown that removal of the endometrioma prior to IVF will certainly increase the requirement of gonadotropins to stimulate that patient, will prolong the days of stimulation, will reduce the number of mature oocytes retrieved. At the same time, it did not improve fertilization rates, so it did not improve quality of eggs, not for pregnancy rate, and not implantation rates. So there's no benefit on clinical outcome, but there is a certain, like Professor Abogar said, certain negative effect on the patient response. Now, what about the impact of endometriomas overall, the surgical treatment of endometriomas overall? As you can see here, treating endometriomas versus patients who had an endometrioma intact and untreated, surgical treatment did not impact live birth rate in this meta-analysis, did not impact clinical pregnancy miscarriage rates. However, it did increase the dose requirement and it reduced the ovarian reserve. So these are major studies, and that's significant, although this is level 3A evidence, but that's what's available. And remember, this is not without cost, financial, physical, that's significant. Now, how would a surgical treatment impact the number of follicles specifically? This is a study that addressed the number of oocytes that are retrieved compared to expectant management following surgery. It shows clearly that an average of 1.5 oocytes less, that is a range of 1 to 3 oocytes less, are obtained after surgery, while at the same time not improving any of the clinical parameters and certainly not improving miscarriage rates, as some schools from Europe believe. And so surgical improvement will make this, a surgical excision will make this patient lose 1 to 3 oocytes for the next cycle. How would that impact the ovarian reserve in terms of AMH units? Well, this meta-analysis has shown that once you treat endometriomas, you're certain to lose 1 to 2 units in terms of AMH. Even if you look at patients with high ovarian reserve, like those patients with an AMH above 3.1 nanograms per ml, and you say, you know, you have no problem, you have good reserve, let me remove that. I'm tempted to remove your endometrioma. Look at the loss, 1 to 2 loss in AMH. That's 3 is gonna become 1 to 2, and that's significant in terms of outcome. And look at this study that exemplifies what we have been talking about. This study has shown preoperatively in 65 women, the average AMH was 1.78. 6 months after removal of endometrioma, it went down to 0.7. That's not what you want to see in your patients. At the same time, when these people looked at the parameters that influenced significantly the drop in AMH, they found 2 things. A cystectomy of an endometrioma 5 centimeters and above, and the removal of bilateral disease. So these are 2 things you want to avoid: larger size endometriomas and bilaterality of the disease. You should never go in for surgery. You're certain to destroy the ovarian reserve and potential of these women. Now, what about medical treatment pre-IVF? We have been, through the longest time, special recommendations by major society on the basis of level 1A evidence, ASRM, NICE, ESHRE. Anytime you do IVF, it doesn't work and you have endometriomas, surgery do not go through surgical treatment, but recommendations are you medically treat, suppress the pituitary with GnRH agonists for 3 to 6 months, and then you improve the outcome. Let's evaluate these recommendations. Here's a study, Cochrane review in 2006. Now, the main problem with this is that the authors could not find in the literature any significantly RCTs of value, right? So it was very hard to find those. But at the same time, they put them together and found 3 studies that date back to 1992 to 2002. And they found out that actually the clinical pregnancy rate after suppression of endometriosis for 3 to 6 months with GnRH agonists have a 4-fold improvement in the clinical pregnancy rate, which was significant, right? But if we go into and that's level 1A evidence. But here I invite you to read what the authors have written in their own meta-analysis, because oftentimes we look at the general picture and we make inferences and we build practice based on these. But if you look at the struggle the authors had to find the proper evidence in the literature, and they could not even found, we understand more the value of the suppression for 3 to 6 months. So I invite you to look with me at every single study included here separately. This is one coming from Israel in which the investigators treated suppressed patients with severe endometriosis with 6 months of GnRH agonist in protocol B, followed by IVF. Protocol A was the control, and it consisted of monotropin stimulation without any form of agonist or antagonist. Now, automatically, when you look at that, you see this is not the way we practice today, because we use GnRH analogs, whether antagonists or agonists. And studies have shown 20 years ago that the use of an agonist was one of the major reasons for the mere increase in the success rate and success outcome of IVF. So when we use a protocol without GnRH agonists, we're automatically putting the control group at a disadvantage, as you can see on this picture. So who does have a clinical pregnancy rate of 3 to 4% in the presence of an endometrioma if you do not suppress for 6 months of GnRH agonists? This goes without saying that this study has put at a disadvantage the control group and gave an advantage to the GnRH agonist suppression. So we cannot tell if it's the 6-month long suppression or the simple use of GnRH agonist that has caused the improvement in success rate. And therefore, this study is probably not fit to be even quoted at this stage or even utilized to prove that point. Now, we come to the next study, which is Ricky's study. In this study, women with stage 2 to 4 endometriosis following surgery were randomized into either 6 months of GnRH agonists followed by 3 cycles of ART, or immediately going into ART. So you can see randomization was great. You had 55 cases in each arm. However, after randomization, they gave the patient the option to go for IUI or IVF. And when a patient in the first arm has gone through 6 months of GnRH agonist, she's anxious to start an IVF cycle because she's already lost so much time. So you had 28 women in that arm. Whereas the woman who, after surgery, was given the choice, they favor more going into an IUI because they have time and they don't want to rush into IVF. And so you have an imbalance between the 29 and the 19. And it simply defeated the purpose of randomization. So this study cannot be even considered randomized. And in that, certainly they found that the agonist suppression had a better, prolonged suppression was a better outcome, but it's certainly not bad at this stage. But if we want to take a message out of that, the message would be that stage 2 disease had no improvement in outcome when prolonged suppression was. Now, so this study again is out. We come to the last study. These patients were suppressed for 3 months with a long protocol GnRH agonist, compared to the control group, women who received the GnRH agonist normal protocols, but it was a mixed bag of apples and oranges. That is long suppression agonist, luteal GnRH agonist, and the flare. And we know that the success rate of these two is not equal. And therefore, automatically the control group is at an advantage here. And these apples and oranges were mixed together. And that's one of the failures of this study. At the same time, if you look at the square, you see that in one group, you see more stage 1 and 2 disease, which according to the previous study will not affect the outcome, will not affect the outcome of endometriosis treated with ART, and therefore will not benefit from agonist suppression for a long period of time. So already it messed up the randomization. And therefore, even though the study found a higher ongoing pregnancy rate, this is probably not valid. So if you take out these studies, 3 studies from the meta-analysis, we found out that we do not have a high quality evidence to support that prolonged suppression of the GnRH agonist will improve IVF outcome. And so we're back to point 0. And everything that these societies, prestigious societies, have built on is based on nothing. This is not even level 1A evidence. And so that puts in question this whole practice again. And until we have a well-randomized trial that reflects our practice today, high quality, we cannot promote medical treatment for 3 to 4 months with a treatment that's expensive and that's emotionally stressful and that is harmful at times before IVF. We'll put all this together in a take-home message chart. You're faced with women with severe disease, endometriomas. If a woman is above 35 years of age, you're worried about factor time. So if you have the option to go for surgery or ART, you tell her, don't touch your endometrioma, go to ART straight away. If this woman is younger, then if she's got a low ovarian reserve, again, you tell her, don't mess up your reserve and go to surgery. Go to ART right away. Now, if this woman is young, has an excellent ovarian reserve, there are 2 possibilities. If she has bilateral disease, you would tell her, I will not touch your ovaries because studies have shown that when I touch both ovaries, I'm going to destroy your reserve. And this, if this woman has tubal obstruction, of course, you're not going to do surgery for her. It's futile. And if she's had past surgery, studies have shown that past surgery affects negatively the outcome of IVF. So I'm not going to do, if you have one of those, any kind of surgery at your young age and you're good ovarian reserve to go to ART right away. But if you're young, and if you have a good reserve, and you have unilateral disease, and you have patent self-tubes, no previous surgeries, then you have 2 options. Option 1 is to go for surgery, and I will guarantee for you a 50% success rate in the next 3 years. But if you go to assisted reproductive technology, I will guarantee the same success rate over the next 1 month. What do you think patients are going to opt for? And thank you very much for your attention.
Johnny?
Yes.
Exciting presentation.
Thank you very much.
I love it.
Thank you.
And also Professor Abulghar made me think a lot after his presentation, but I will leave my comments till the end. However, congratulations. After this lockdown for 5 months, we're back to science. We're back to remember basics and advantages of new technology. And I would like to thank Professor Salam for organizing this webinar and Mina Pharma as well. So now the time has come to introduce the president of the society, the Middle East Fertility Society, Professor Boutros Rizk, our dear colleague in Alabama, in USA. And
yes, hello.
You're welcome to the panel.
Thank you.
And we are ready to listen to your precious word.
Thank you. Thank you so much. Thank you, Dr. Michel. Thank you, Professor Salam.
Oh, I see what you're saying. Okay, I got you.
Thank you for giving me this wonderful
okay.
To share this session with you. We actually had another audio interfering, but that's okay. I think we should be good. It's a great honor for me to be a part of this distinguished panel. Enjoyed so much Dr. Abulghar's stimulating topics, as I can see now the spirit of the editor of the journal, and of course Johnny's clinical input that is so wonderful. It's a great pleasure for me to add a topic, although not directly related to these 2 topics, which is really the impact of the oxidative stress on the outcome of ART. It's a controversial topic this year. Yaqub Khalaf and I just published a book on controversies in assisted reproduction. And basically all the topics that Dr. Abulghar has covered this afternoon, one by one, swiftly and elegantly are topics for controversy, whether you do PGT or not, whether you do scratching or not, whether you do hysteroscopy or not. And unfortunately, as he highlighted, that the evidence is still lacking for many of them. For antioxidants, the evidence is still about to be collected. We're not even to the point of refuting it because there has been so far very little evidence for that. You think that's good? That's better now?
Yeah, this is perfect. Thank you.
All right, and let me see here. So the topic of oxidative stress is of course a very well-known topic today. It used to be a research topic, but now it is considered an important topic. Oxidative stress is a balance or imbalance between two issues, between a clearing mechanism where you have antioxidants and between a damage mechanism where you have excess of reactive oxygen species. Whether it happens in the body, for example, because of macrophages trying to combat infections, or whether it happens in culture medium because of strenuous condition in incubators and otherwise. There is several series of reactive oxygen species, whether these are superoxide, hydrogen peroxide, and many of them one by one. Where are the sources for those in natural life? Basically, there are exogenous and endogenous. The exogenous comes from smoking, from alcohol, from pesticides, from infection, from inflammation, even without infection, varicocele, radiation in the environment, and so forth. Endogenous comes from things like, for example, excess of leukocytes, immature spermatozoa in sperm dysfunction, and so on. And then there could be also other sources like psychological issues, like extremes of physical fitness, which is a big thing in America. I don't think that's common in the Middle East. Advancing age, old age definitely increases the oxidative stress damage and so forth. Altogether, there are many issues. If you look at some on the right, they are common in the Middle East, like smoking and obesity, preponderance of smoking and obesity. You look on the left side in the US, maybe alcohol and marijuana. We see drugs and so on, but this is not common in the typical group of patients going through IVF and infertility. This is more common maybe in other groups in the population. So these are what we see in the environment as causing oxidative stress in the female reproductive system. And again, the balance between the two would make the final outcome of which one wins and the other. Male infertility in particular has been extremely well studied. Female infertility has been poorly studied at best, or very limited studies that have been done on the impact of oxidative stress on the female. Partly because it was very easy to attempt measuring the male infertility stress, oxidative stress, because of its availability of sample to exogenous stressing. So when we look at many of the techniques that are now available, from flow cytometry to ELISA to enzymatic antioxidants to chemiluminescence, there are plenty of them. The most recent that has been validated internationally by multiple male infertility centers is called the Myoxis, or one of the mechanisms that look at ORP in the semen analysis and correlate it with the number of sperms. When we look at the female, there is very limited analysis as how you can measure the oxidative stress in the female. At the same time, when you look how does the damage affect the eggs or the embryos, when you see a cartoon like that with too many of them, you know that we're not sure which particular mechanism is the cause of the problem. It could be gene mutation, could be deletions, could be chromosomal rearrangement, could be DNA cross-links, and could be single and double-stranded DNA breaks. So many mechanisms contribute to the damage of the eggs. What about the physiological role? Like, why is there oxidative stress anyway? By the way, you hear me well or you don't hear me well? You hear me? You hear me well?
Yes, we hear you very well, Peter. Continue.
Very well, very well. We can hear you very well.
So the physiologic role of the oxidative stress elements is basically because of possibly affecting the maturation of the eggs, affecting the folliculogenesis, also the corpus luteum, as well as the implantation in the endometrium. So what about folliculogenesis? What is the evidence that is involved? The biggest evidence is that if you measure the oxidative stress in the blood and you measure it in the follicular fluid, you find that the follicular fluid actually has less oxidative stress than the blood, meaning that the body has intervened in a way to decrease the amount of reactive oxygen species immediately surrounding the eggs compared to what you have in the blood altogether. Also, if you measure the nitric oxide, you find that there is a difference in the nitric oxides in the different follicles as well. So does any issues that affect oxidative stress affect the follicle? Yes. If you have, for example, extreme situation of vitamin C deficiency, it results in damage to the eggs. If you also have imbalance of certain antioxidants like glutathione and vitamin E, there are many studies that suggest today they have an impact on folliculogenesis as well. What about the endometrium? Perhaps the endometrium, and this has been a particular area of our own research, is the most subjective to oxidative stress. And I'll show you in a very simple cartoon, what would that effect be? If you take two simple scenarios, the scenario on the left is no pregnancy with a menstrual cycle, and the scenario on the right is a pregnancy. So you take a pregnancy, you ovulate middle of cycle, you start implanting 6-7 days later, you have HCG, it results in an increase in progesterone. You have an increase in progesterone, there is an immediate increase in the superoxide dismutase, and there is an immediate decrease in the cyclooxygenase and the PGF2 that is confirmed in studies, and hence you don't have the expulsion of the endometrium known as menstruation. If you take the opposite side, a woman does not ovulate naturally, does not have HCG from the implanting embryo, the progesterone will drop, the superoxide dismutase will drop. Oxygen radicals will increase, and if you actually take endometrial tissues and we measure the cyclooxygenase as we did, you find an elevation in the cyclooxygenase, and you cite also an elevation in the PGF2 alpha, and hence you have the expulsion of the endometrium or implantation. So the endometrium is probably one of the easier ones to measure because, of course, the tissue is amenable to evaluation, and there is no question that the elevation of progesterone as a result of the natural HCG results in a decrease in the COX-2 and a result in a decrease in the PGF2 alpha and the lack of menstruation. What else, again, with as far as oxidative stress, you mentioned endometriosis elegantly. A part of the endometriosis problem is oxidative stress, and we used to think it's the iron. The iron is not part of it, but the iron could act as a catalyst in some of the enzymes that work. There is also excess interleukins and phagocytes in the peritoneal fluid. This has been a long time ago work by Dr. Badawi in upstate New York. And that phagocytic effect produces a lot of nitric oxide, hydrogen peroxide as part of the mechanism to combat what the body perceives as an inflammation. And hence that increase is part of the mechanism of development of oxidative stress in endometriosis. What about PCOS? There are two issues with PCOS. There is a first issue is a mitochondrial dysfunction, which have been studied in PCOS patients. The second is that there is an element of insulin resistance and an increase in inflammatory state. So the inflammatory state has nothing to do with infection, but in the presence of PCOS, there is an abnormality in the cascade of pathway after the attachment of the insulin to the cells, and increase in inflammation. So altogether, oxidative stress could affect infertility at the level of the damage to oocytes, whether at the level of the lipid peroxidation of the membranes or DNA damage. At the level of impaired fertilization, we assume that as a result of change in the peritoneal fluid content, you can have a certain degree of apoptosis and resulting in embryo fragmentation and possibly implantation failure. And then finally, I alluded to the endometrium and corpus luteum function. If you have a hydrosalpinx, we're all in agreement that the hydrosalpinx, the fluid in it, the hydrosalpingeal fluid, does affect the pregnancy rate and miscarriage rate. Possible mechanism of that is through oxidative stress to the embryo as well. What about ART? All this is as far as natural pregnancy. A very elegant work done by Professor Campbell, the legendary gynecologist from London many years ago, showed that in women who have a small number of follicles, if you measure the blood flow in certain follicles, and you do an egg retrieval that you correlate that particular follicle with the egg there, you will see very clearly that the quality of the eggs correlate with the perifollicular blood flow if you do Doppler on those. But this is possible for patients who have a limited number of follicles and a limited number of oocytes as well. And how does that affect the embryo? It possibly could affect the embryo division, the cleavage stage, and the development of blastocysts as well. And you can summarize it again, seeing at the IVF level, it could affect the fertilization, could affect the cleavage, could affect the embryo, and so forth. And then you attempt to improve them by working on them by working on two particular pathways that we've worked on, which is the oxidative phosphorylation and the NADPH oxidase. Having said all that together, we want to see, so what is the clinical evidence today on the studies that have been done? And I want to focus on two studies in this talk. One of the studies is a very recent study performed by the group from Melbourne, Australia, by David Gardner, and published in RBM Online earlier this year in May. And the second is really our study, which we have done by clinical oral supplementation. How would that possibly work? It possibly still, we assume that it works on the oocytes. We try to analyze the difference in the outcome to see, did it affect fertilization? Did it affect blastocyst formation? Did it affect implantation and clinical pregnancy rate or not? And this is what I'll show you in the two studies. To summarize to you all the previous history of the studies, in 3 words, the studies up till the 2000, showing 3 groups, showing a group that supposed that oxidative antioxidants would improve the outcome, group that show it doesn't have any impact, and a group that showed that it worsens the outcome. Unfortunately, the group that studied the improvement of the outcome were done in the 90s, and there is nothing wrong with the 90s studies, except the fact that they work on the blastocyst development, and we all know that by the 90s, we were doing mainly day 2 and day 3. I remember one of our studies in 92, we did a day 3 instead of day 2, and the study was presented by our embryologists, and it was attacked fiercely by a group from Melbourne, Australia, because we were very aggressive and moved to day 3 from day 2. There is also the group of studies that show no effects. And then finally, there is even 2 studies that's showing an increase in ectopic pregnancy rate or other damage. So, and if you see the last studies that we've done that were seriously affecting the outcome were 2012. Most of the blastocyst studies were done between 1994 and 2003. So we took 2 approaches in this talk. What about clinical supplementation of oral antioxidants, and what about IVF supplementation, which is the David Gardner study that I'll share with you. It's actually one of our books with David Gardner. He's definitely a very dedicated scientist that particularly he worked on the blastocyst culture. So he had an interest in supplementing the culture medium. So he used his blastocyst culture system in the control group, and in the actual study group, he added 3 antioxidants: N-acetylcarnitine, N-acetylcysteine, and alpha-lipoic acid. What did they look at? As an embryologist, they look at the quality of the embryos on day 3. They looked at the quality of the embryos on day 5 and 6, the quality of the blastocyst, and the clinical pregnancy rate. So it was a prospective randomized multi-center study of sibling oocytes. They based all together, looked at 133 IVF patients. They had approximately 1,563 metaphase 2. The control group, again, was the standard culture media for blastocyst without any antioxidants. And the study group was the supplementation of the IVF culture medium with N-acetylcarnitine, N-acetylcysteine, and alpha-lipoic acid. When they looked at day 3, they looked at the good embryos would be day 8 to 10 cells, would be equal blastomeres, would be low fragmentation. When they look at blastocysts, they looked at 3 BB. Clinical pregnancy rate, they looked at the number of gestational sacs per embryo transfer or per oocyte recovery. And these are the results from the study. Again, 1,563 eggs in 133 IVF cycles from Melbourne, Australia. They looked at the good quality day 3. There was a 40% good quality in the blastocyst culture media, and 50% when actually they added antioxidants. When you look at the gestational sacs, again, it was 39% versus 50%. And when you look at the cardiac activity, it was 37 and 47% respectively. So they narrowed, and these are the bar charts that I have done for their study. Again, looking on day 3, going from 40 to 50, good quality, and looking at the gestational sac and the cardiac activity of the embryo from 37 to 47%. They narrowed their analysis to the women between the age of 35 to 40 age group, and the gestational sac here, there was basically doubling in the rates. So the numbers here are more impressive in the older group of women in the 35 to 40. In general, there is agreement about that basically there is more mitochondrial dysfunction with aging, and there is also the degeneration of the quality of the ooplasm as a result of many things, whether endoplasmic reticulum or other issues. You look also at the cardiac activity. If you look at the cardiac activity here, it is doubling the rate of the cardiac activity, and you look at the ongoing pregnancy rate, it is double the ongoing pregnancy rate. And I made those bar charts yesterday for their study, showing you basically the gestational sac, cardiac activity, and ongoing pregnancy rate after 20 weeks. On this side is the bar chart for the antioxidant supplementation, and on that chart for the indeed the blastocyst culture medium. So they concluded that the presence of antioxidants in the culture medium during IVF improved the pregnancy rate in implantation rate in women between the age of 35 to 40, and that is possibly through decrease of oxidative stress. This was published on May 1st this year. We have just very recently completed in the process of actually publication of our study, which we look at oral antioxidants in women that are going through in vitro fertilization. We looked at three things in this study. We looked at clinical pregnancy rate per embryo transfer and per oocyte recovery. We looked at the blastocyst rate, which is basically the number of blastocysts divided by the number of 2PN. And we look at the fertilization rate, which is the number of 2PN divided by the number of M2. So these are the three things that we looked at in our study. It was a prospective study of the IVF patients between October the 1st of 2018, when we got the IRB approval, till actually July 15, when we did our final analysis. We looked also at the cohort group on a preceding group of IVF. And this could be taken as the only limitation of, or as the limitation of the study, is that we did not do a prospective randomized controlled trial. We used the cohort study. The prospective randomized controlled trial would, of course, be more powerful and also would need more time to do until we get patients that would be randomized. We looked at the patients between the age of 20 to 40. We, of course, obtained the informed consent and giving them the IRB forms. We included all the ethnic groups. So this study was done in our center in Texas. So the majority of the groups were either Hispanics or Caucasian. Very minority Black population, just simply because of the distribution of the population in that area, with the majority being Caucasian or Hispanic in that group. We excluded women who've had cancer because there is an element of increased oxidative stress. We excluded women who've had surgery in the last month to two of the study, have had trauma or accidents, and have issues with the GI like Crohn's disease or ulcerative colitis as well. We disqualified patients who, after being enrolled, had the same issues as well, or have been taking on their own high amounts of vitamin E or vitamin C or selenium or zinc or N-acetylcysteine. Altogether, we recruited 400 IVF patients between October 1st of 2018 and July 15 of 2020. 124 of them now have been interested in the study and were involved. And in this group of patients, 76 have met the eligibility criteria and have accepted 90 days of antioxidant treatment as well. The control group, same age, 21 to 40, matched for age, matched for BMI, which is an important issue. We've excluded the cancer, the surgery, the trauma. And then finally, we ended up with the two groups, matched 102 IVF patients, 51 in each group. And we completed the analysis on 33 that had all their embryos transferred. So this is the analysis as of a week ago. 33 patients in the study group that have received antioxidants and have, including, besides the vitamin B, C, E, selenium, zinc, have also included N-acetylcysteine and alpha-lipoic acid and carnitine. And we've seen an improvement in the fertilization rate from 57% to 63%, which was not significant. We have seen an improvement in blastocyst formation from 37 to 43%, which was not significant. We have seen a clinical pregnancy rate, which is basically seeing a gestational sac and fetal pole at the time of ultrasound, that was increased from 36% to 67%. We must have liked that we did not take and I'll come to the endometriosis when Johnny stopped taking, because I was one of the reviewer for the 1989 study that was by Dov Dicker at the time. And the point he made was quite elegant. They took their first study, women who failed a certain protocol, and they moved them to a new protocol. And in the first protocol, they took 100% women who failed. So there was 0% pregnancy. And then the new protocol, they got to 30%. So that immediately made a statistically significant difference. Here we took a woman, basically 37% pregnancy rate before the antioxidants and 67. This doesn't mean that the antioxidants is the only factor, but it was one of the few variables at this period of time. This is our results on this study, showing you an insignificant change in the fertilization in favor of the antioxidants, a non-significant increase in blastocysts, a significant increase in clinical pregnancy rate determined by the gestational sac and fetal pole at the time of the 6 weeks ultrasound compared to before. We conclude here that from our study that the supplementation of antioxidants might be a factor that should be considered in those patients. Of course, RCTs are needed to establish any clinical guidelines, but particularly in supplements. We concluded from the David Gardner study that also other IVF centers would use their protocols. I also like in their study that their baseline or their control group pregnancy rate was satisfactory, similar to ours. So we did not pick a pregnancy rate, for example, of a control group of 10% or 20%. We picked an almost a 40% clinical pregnancy rate. To beat that benchmark was quite difficult. We did not have a significant increase in blastocyst formation rate. I do not necessarily have a reason for that, but this is where we stand. We definitely need a prospective randomized control trial. Like I said, we just published a book on controversies, so in assisted reproduction. So I don't want to add another controversies, but I would like to add that because of what you said, Professor Abou-Gar, about Peter Brodie, my former colleague from London, and he was actually before me at Cambridge at the same institute. He was actually lecturer at Cambridge before I joined in 1990, before he became the London professor. He said that what other discipline in medicine accept the 70% pregnancy? So that is why we're searching for everything, and we're turning every stone, because 70% failure rate is not exactly what we're looking forward to. And I thank Dr. Salem again for giving me the chance to publish with him those two books, an infertility assisted conduction and this particular book that he personally wrote single-handed, page by page, when he was in London in 1979, 42 years ago. Thank you so much for your attention this afternoon, and looking forward for an exciting discussion.
Professor Rizk, for a beautiful presentation. Starting from what you have just finished, and Abu Abdallah. Now, these patients who had antioxidants, were these patients with oxidative stress, or were these patients across the board? I mean, did you measure the oxidative stress, and only those who had oxidative stress then were given antioxidants, or was it just general patients?
Yes, so that's a very interesting study. So part of the researcher in that group were the people from the Cleveland Clinic that actually developed the measurement of oxidative stress using the Myoxis technique, which is widely used now, or widely standardized, shall I say now, in male infertility. We attempt, so it's a totally different study. It's a totally basic science study that I have actually 2 PhD people working on it, that is attempting to measure the oxidative stress in the female by measurement in the follicular fluid. The measurement is very cumbersome in the female compared to the male. So in the male, the oxidative stress is measured in the semen in relation to the, as you know, to the number of spores. So it's measured as 1.34 millivolts per million sperm. In the female, the quantification cannot be done easily or at all. So we had to compare either the follicular fluid of that group of patients before supplementation and after supplementation. So we're doing it on another study on women who failed and postulating that failure could be to many reasons, because some of them had good embryos, but still failed. So we're measuring it on follicular fluid. So in answer, no, in this particular set, it was offered to everybody, except of course azoospermia or so on. But we offered it to tubal factor, to endometriosis, to anovulation like polycystic ovaries.
I have a small comment and a question. Boutros, IQ presentation, and really you presented the data which is convincing. Because I'm saying that because most of the supplement vitamins or antioxidants in the market, they were introduced with a very few studies that really are convincing. This study is really, I like it, the presentation and the study you presented. However, the antioxidant that you have mentioned, the 3 antioxidants, are only the 3 antioxidants that we have to use in all these cases, or the 3 antioxidants they have this effect on the endometrium outcome, etc., or there are other antioxidants that we can use, such the coenzyme Q10, that might improve the factors that you have mentioned in your presentation.
Thank you, Dr. Michel. Thank you first for your nice comment. Your question is excellent. Before the meeting, Dr. Salem and I, we decided to hide the brand name of the drug so we concealed it from the study. But now that you have asked, I'll share that with you. The supplements that we used is an American supplement by the name of FH Pro, made by Fairhaven in Washington. The reason I'm mentioning it is that we studied the details of the constituents for a long period of time. So we do have 300 milligrams of CoQ10. We have selenium, we have zinc, we have, of course, vitamin A, B, and C, and so forth. We have used multiple other, for example, in women, a very small dose of melatonin, 2 milligrams of melatonin. We have used in men, because there is supplements for his and her, N-acetyl carnitine, 2,000 milligrams per day, which is a big dose. We've used in women the N-acetyl cysteine in a higher dose than in men. We used 100 milligrams of cysteine in women. We use 50 milligrams in men. So your question is, of course, is really the key question, because it depends on what you add. So for example, with Gardner, he picked 3, but with us, we literally used approximately 40 in so on. But we have used those same 40 for a number of years now, perhaps for the last 3 years without a study. And then at the end, we decided to do the study in a controlled fashion. And very frankly, I attempted to do it, I wanted to do it in a prospective randomized controlled trial, but would have taken a longer time, would have needed a large number. We had to screen 400 IVF patients to do those. But your point is very, very well taken. And we did add coenzyme Q10, 300 milligrams. We added many other things, including alpha lipoic acid, acetylprotein, molybdenum, zinc, selenium, ascorbic acid, all the vitamin B5, B6, pyridoxine, and so forth.